Hi guys, welcome to another day of studying pharmacology one drug at a time. And for today, we're going to talk about dopamine. So, let's start. As I've mentioned in the previous videos, dopamine is a dose-dependent adrenergic agonist, and it is used mainly in critical care settings for hemodynamic support. Again, its mechanism of action varies with the dose, meaning at low doses, it primarily stimulates dopamine receptors, leading to effects such as renal vasodilation and increased urine output. At moderate doses, it activates beta 1 receptors, increasing heart rate and contractility, which improves cardiac output. And at high doses, dopamine stimulates alpha 1 receptors, resulting in vasoconstriction and elevated blood pressure. When it comes to dopamine's clinical uses, dopamine is used in shock states, particularly when there is hypotension accompanied by bradycardia or low cardiac output, such as cardiogenic shock. While it's not the first-line vasopressor, that role belongs to norepinephrine, which we have already discussed. You can check the link on the description. Dopamine may still be preferred for vasopressor effects when both inotropic and chronotropic support are needed. It is also favored in certain cases because, unlike other vasopressors, it does not compromise renal blood flow and may help preserve kidney function. Dopamine can be related to norepinephrine and epinephrine in that it can stimulate adrenergic receptors. But again, it is a unique dose-dependent receptor selectivity that sets it apart. And a helpful mnemonic to remember this is do, beta, alpha, referring to dopamine, beta, and alpha as the dose increases. Again, do, beta, alpha. When it comes to significant drug interactions, dopamine should be given cautiously to patients taking MAO inhibitors. MAO or monoamine oxidase is an enzyme that breaks down dopamine, norepinephrine, epinephrine, or the catecholamines in general. So if a patient is on a MAO inhibitor, these catecholamines are not broken down properly, leading to excessive accumulation. So if dopamine is given to a patient taking MAOI, it builds up its toxic levels, leading to extreme vasoconstriction and hypertension, or commonly called as hypertensive crisis. Another drug interaction is if a patient is on a beta blocker, dopamine's beta 1 stimulating effects are reduced or blocked, so the expected increase in heart rate or cardiac output may not occur. Meaning, beta blockers make dopamine less effective in bradycardic or low output states. And using dopamine with other vasopressors can cause excessive vasoconstriction, tachycardia, or arrhythmias due to additive or synergistic stimulation of adrenergic receptors. In short, proper titration and monitoring when using vasopressors in combination to avoid the overstimulation or ischemia. And another one, the TCAs or tricyclic antidepressants, they tend to increase sensitivity to dopamine. So TCAs like amitriptyline, they block the norepinephrine reuptake, leading to increased levels at the synapse. So they may also interfere with dopamine metabolism or reuptake. So the dopamine effects are amplified when TCAs are present. It can lead to an exaggerated response such as higher blood pressure, heart rate, and risk of arrhythmias or hypertensive episodes. Another related drug that I want to add in this discussion is the drug Dobutamine. Dobutamine is a selective beta 1 adrenergic agonist. It is primarily used to increase cardiac output by enhancing myocardial contractility, making it especially useful in cases of acute decompensated heart failure or cardiogenic shock. And unlike dopamine, dobutamine does not significantly stimulate alpha receptors, so it has a minimal vasoconstrictive effects. These characteristics makes dobutamine a better choice when improving cardiac performance is the goal without raising afterload or causing excessive vasoconstriction. While dopamine offers both inotropic and chronotropic support with dose-dependent alpha activity, dobutamine provides a cleaner inotropic effects with less risk of tachyarrhythmias and better perfusion in patients with low systemic vascular resistance. The common side effects of dopamine include hypertension, cardiac arrhythmias, nausea, and ischemia at high doses due to vasoconstriction. And like other vasopressors, it should be given via central line when possible to avoid tissue necrosis from extravasation. Again, dopamine is not the first line in septic shock, and it acts like three drugs in one dose-dependent switch in receptor activity. And always consider a central line administration and monitor closely for arrhythmias. And those are the things that we could learn about dopamine. And before we end this discussion, let's have a sample case here. We have a 68-year-old male presents to the ICU with cardiogenic shock following myocardial infarction. And his blood pressure is 90/60, the heart rate is 55, and he has signs of poor perfusion, and the lab shows elevated creatinine suggesting worsening of the renal function. So again, let's interpret it. There's hypotension, bradycardia, and low cardiac output, and renal perfusion is a concern, and the patient needs both chronotropic and inotropic support. So the drug of choice here is dopamine. It is chosen over dobutamine in this case because it provides both inotropic and chronotropic effects. And it may also help preserve renal blood flow due to low-dose dopamine's renal vasodilation effects. In an alternative scenario, if the patient had normal blood pressure but low cardiac output, dobutamine would be preferred for its strong inotropic support without causing vasoconstriction. So that's it. I hope that this could help you learn about dopamine, and I hope that the memory aids and sample case could help. And if you have questions, suggestions, corrections, or additional information, feel free to put them in the comments so that we can discuss it. And don't forget to subscribe for more videos like this. Until next time of studying pharmacology, one drug at a time. See you on the next drug.